So this is dangerous. I have a mic, so we'll see how this goes. If I bust out in song, I apologize.
I'm the same way you think in life.
All right. So I'm very excited to present the research that I was doing in the Democratic Republic of Congo, which is evaluating the use and potential for broader adoption of a saliva-based malaria detection system in Sub-Saharan Africa. So I'm presenting it today. Willis is not going to be able to make it. And we have co-authors here in the room. So Colby's in the room, Cody is also involved. And then some folks from the Emerging Pathogens Institute at UF, Dr. Roel Dinglasen and Casey McCoy. And then our great partners there in the Democratic Republic of Congo who are also co-authors on this presentation. So we had an amazing team, a lot of great collaboration to make this all happen.
Do you want to run it?
All right, so a little bit of a background. So before I got involved in this project, I realized malaria was an issue, but I didn't realize how prevalent it still was. In 2019, there was 229 million cases globally and 409 deaths. 67% of those deaths, which is about 274,000, were children under the age of 5. And that equated to one child dies every 2 minutes, which blew my mind. So nearly half of the world's population is at risk, but as you see, 94% of the cases occur in the World Health Organization's Africa region. And so 6 countries accounted for half of those deaths. So it was Nigeria, the Democratic Republic of Congo, Tanzania, Burkina Faso, Mozambique, and Nigeria. So despite these long-term widespread efforts, there's still a lot of spread of malaria. So it calls to question how effective are these global control efforts? A large proportion of the population is responsible for what's called residual transmission due to the issues with the blood-based system. And I'll explain a little bit more what that is. So the Dinglasen laboratory housed within the UF Emerging Pathogen Institute took the lead in developing and implementing a new saliva-based malaria detection system. And that is Dr. Dinglasen right there. So this is one of the foundational pieces in the testing of the saliva-based approach. I won't go into that article if you're interested in it. It's in the Science Translation of Medicine journal. So here, this is a graphic that helps to explain the issues with the blood-based system. So if you look at the red and the blue in the middle, so rapid diagnostic and microscopy, that's related to the blood-based system. And so the challenge is it does not get folks at the pre-symptomatic phase. So it doesn't allow you to get to the path of treatment and isolation before you're symptomatic and contagious. So it's called SMART-1. Is the acronym for the system. It helps to extend the ability to detect malaria in that asymptomatic or pre-symptomatic phase, which is critical to mitigating the spread of malaria in Africa. So this is a picture of one of the saliva-based technologies. It's a multiface process, which is essentially saturating a medium and then testing that medium for malaria. So the theoretical framework we use for this is DOI, and this is actually a picture of another technology that developed too. So there's the swab-based and there's also the spit-based technology. It's the same basic tenets, saturating a medium, testing that medium. So we use DOI to understand how the participants view relative advantage of the saliva-based technology, how compatible it is with their current testing system, how complex they viewed the technology, if they were able to observe the technology and use it before actually using it more broadly. All right. So our site that we did our test was in Kinshasa province in the Democratic Republic of Congo. We did data collection in September 2021, which was a challenge because, as you can tell, it was right in the smack dab middle of COVID. And we used 3 data collection techniques. So the first step was conducting a training on the technology. Then after that training, we conducted observations of the participants to see how effective they were in administering the test. We conducted a survey using the DOI as a construct to understand their perceptions of the technology in reference to the blood-based system. And then we conducted focus group interviews to really unpack, what their thoughts were with the blood-based, what advantages or disadvantages existed with saliva-based, and then considerations that we needed to understand to ensure broader adoption of the technology. So, as I mentioned, participants were engaged in the training to administer that saliva RDT. So first was the observation, the collection through observation. So these are the 21 steps that are part of the protocol. So we essentially created observation checklists where we trained the observers, and these were the medical professionals that helped with the initial development and training. And then they observed and were able to delineate, hey, are they doing this effectively or not? And then taking notes to give back to that person that they trained to give them insights on how they can improve the administration of the practice. The survey used 9 Likert-type items related to the DOI construct. We originally wanted to have different indices for each of the DOI, but since we're going to engage them in observations, surveys, and focus groups, we didn't want to exhaust them with data collection. So we created kind of an all-encompassing DOI construct. And then the dependent variable that was measured against was likelihood of adopting the technology and integrating that into their current testing regime. We also collected demographics on sex, age, education, occupation, and years of experience in working in the field of malaria testing and treatment. So for the survey, we had 141 respondents. So just a little bit of the demographics of those that were observed and completed the survey. 72% were male, 27% female. You can see the breakdown. It's a lot of younger folks, middle-aged folks. Mostly secondary education, not much folks engaged in university education. You see there's a lot of school teachers that were involved in our group that were actually administering the test as well. We also had community health workers, nurses, doctors, library techs, and some other folks. And then everything ranging from less than 1 year of experience all the way to 15 plus in dealing with malaria. And then finally, we had focus group discussions. There were 6 focus groups that we conducted, 3 with community health workers and 3 with teachers. There were 9 questions included in the semi-structured protocol that really focused on their previous experience with detection and testing, perceptions of the new technology, and as I mentioned, considerations for use and broader adoption. All right, there's a lot going on in this slide, so I'm going to try to navigate these few spots that are important. First, I'm going to point out the additive index box. So essentially, I created an index based on if they were able to successfully adopt each one. So if they did, it was a 1. If they did not, it was a 0. And so it would create a score from 0 to 21. So the mean of those scores was 19.79 with a median of 21, which means that the median score was effectively carrying out every single step. The range was 5 to 21, so those folks are only able to carry out 5, and all the way up to full successful implementation. The interesting part was there was no significant difference across the different stakeholder groups. So a doctor was doing it at the same level of efficacy as a teacher, at the same level of efficacy as a community health worker, so on and so forth, which is super important for broader adoption, especially if you're doing non-traditional actors in the detection process. This observation protocol also gives you opportunities to learn how you can potentially improve your training. So I highlighted those that had the higher numbers of misses. So if you look at the bottom, will correctly record test outcome, place the white absorbent pad end into a plastic compression tube, yada, yada, yada. Lean forward at a 45-degree angle. So again, this just gives them the opportunity to understand, hey, what do folks do well, what did not do well, give them that immediate feedback, but then also considerations for future training as they look to adopt this in other countries in Africa. All right. So as part of the survey, I had the DOI construct, so I created the indices. I conducted correlations between the DOI index and likelihood to adopt, and noticed that there was that significant relationship. So their perceptions were overly positive, and they were also more likely to adopt the technology. We did notice that there was a difference in age and likelihood to adopt, occupation likelihood to adopt in the DOI index, and occupation in the DOI index. There were significant differences identified between occupation and likelihood of adopting the technology, DOI and index. So occupation, as we thought, can have some significant differences, but again, what was interesting is it didn't inhibit their efficacy in administering the test. I feel like I found a trick over this.
Sorry.
So within each one of the items, there were significant differences found among the individual items. So fits well with their malaria detection and treatment system, improve the ability to treat malaria quickly, so on and so forth. The only one that was not a significant difference was it was easy for me to become skillful. They all felt like it was easy for me to become skillful. So again, the perceived behavioral control with this technology was really high. So then I did a little bit of test of difference and noticed that, again, that occupation was a significant difference. And it had a large effect on the way in which they perceived the technology. So the biggest significant difference was between teachers and health workers, and the highest scores on the index were nurses, school teachers, laboratory techs. So those positive perceptions in relationship to the DOI construct also said that they were more likely to adopt the technology. So in conducting regressions, it was significant and showed that there would be a high level of adoption based on those positive perceptions of the technology. Oh, just blow through that. All right. So this is where I really found the data to be interesting. I'm a qualitative researcher, so I love focus group data. So one of the things that they felt like was still a salient advantage of the blood-based detection system was the ability to detect multiple species of malaria. Unfortunately, the saliva-based detection system only detects one, but what you've come to find out is that one is responsible for something like 95% of malaria cases in Africa. The disadvantages of the blood RDT are detection inaccuracy, so a lot of times you'll have false negatives, and there's a high detection threshold. So you have to have a lot of malaria in your system to be detected as positive with the blood-based system. The results are slow in getting back, and a lot of times the process is inefficient. Whenever you draw blood, there's a whole infrastructure around that, so supplying it and the access of a blood-based system is a concern. Some people don't like needles and having their fingers pricked, so that came up in every single one, especially since children are a huge target group. So this is good for them. It takes away the uncomfortable part of it, the pain that they're associated with, and then just the unsanitary aspects and the contamination risks with drawing blood. That's something that in all of the different focus groups they mentioned. So looking at the saliva-based detection system and their thoughts of advantages and disadvantages. One of the biggest advantages they saw was its accuracy in detecting asymptomatic patients. So being in COVID, we can all appreciate that ability to detect asymptomatic patients. The second was ease of use. They all said it was super easy to use, and they really appreciated that, especially as they go to train others within their circles, and it'll be easy to have that larger network and ability to adopt the technology. Efficient and quick results. The results will happen within 15 minutes. Not painful, so you're either swabbing your mouth or you're spitting. It's perceived as new and more sophisticated among the group, so that's something that'll help with adoption. And they feel like it'll be more easily to diffuse more widely. So again, since you're not drawing blood, there's that opportunity to adopt it more widely. So as we know with COVID tests, we have those home COVID tests, right? So we can swab ourselves and test it. It's the same sort of idea. You spit in something, you put it in a solution, you're ready to go. So it also came from the focus groups with some overarching testing considerations. So they identified opportunities to modify the design and protocol specifically for children. They said that there would be some children that wouldn't be able to utilize the technology effectively. Then also the considerations for waste management. And once they're done with the test, making sure they have that infrastructure. They wanted to make sure that these tests were not only available at healthcare centers. So currently the blood-based system is only at healthcare centers, and they felt like for this to be effective, it needed to be available more broadly to increase that access. And then again, they prefer the spitting cup. They like that better than someone jamming something in their mouth. So. 30 seconds, okay. I'm gonna fly through this. So role of key stakeholders. As we know, a lot of us are extensionists, there's a need for strategic communication. And there's a need to connect with those trusted stakeholders in the community to provide a mechanism to get it out to the right folks. So they identify community health workers and relays to help to normalize the practice, and then those teachers, whether in the traditional classroom or out in the community, to help to provide consistent education. Conclusions. So observation shows that following training, that the participants were really able to administer the test with relatively little issue. And the checklist provides opportunities to refine training so that folks are really able to adopt the technology proficiently. Survey results demonstrate the role of the perception of the technology and its broader adoption, and how occupation influences those perceptions and its potential implications on training. Interview results provide insights on how it's a desirable alternative to the fingerprint. There is an opportunity for adapting technology based on this pilot effort, and it really provides some salient considerations for outreach and extension efforts of what we need to be considering in the long term. Saliva protocol increases the access and ability to test, and the ability to identify cases of those asymptomatic early cases is key to mitigate this consistent and residual spread of malaria. I'm just going to go to the thank you slide, because I want to thank my folks. So this was funded by the Global Health Innovative Technology Fund, which is out of Japan. And we wanted to thank all of our local partners that were not authors. Coordinating this in the middle of a pandemic at DCR was a challenge, and so we couldn't have done it without these folks. And then we wanted to thank all the individuals who participated in MOVE, Kimboko, and Linguala, who were in this study. That's it.
Well, I heard a lot, Dr. Diaz, regarding relative advantage and compatibility and there not being very much complexity.
Yep.
You know, I assume, and that's your surmising that had a lot to do with this procedure almost being the same in terms of efficacy.
Yep. It's very similar to COVID testing protocols. And so having that experience helped to streamline the learning curve for this protocol.
Yeah. Questions, comments? Yeah.
I couldn't help looking at a couple of biological facts in the middle of your presentation. I'm missing something about how that early detection actually breaks the parasite cycle. So I know that those non-symptomatic individuals are a reservoir for the organism, and then the mosquito can bite them and spread it to someone else. So how does knowing that the individual is pre-symptomatic, what other intervention is going on there to break that parasite spread?
Yeah. So there's the initial step of getting them the treatment that they would need to overcome malaria. As far as the spread of malaria, that is a Dr. Ding-Lawson question. My focus on this project was evaluating the technology and figuring out within that group what their thoughts were and how the ability to adopt it. But Roel will chat your ear off in regards to how this fits within that larger paradigm of spread.
Perfect.
What role do you see potentially for extension professionals to take part in the dissemination of this very easy to use technology, especially to rural, very rural areas?
So a lot of the work that I do is, I'm a big fan of partnering UF-IFAS and the College of Medicine, this partnership between health and IFAS. Public health professionals are very proficient at developing technologies, understanding medicine, understanding how to work with these different medical technologies and medical diagnosis. But we're the experts in trying to figure out how to get in these communities, develop communities, and allow them to understand how this fits within their areas of need. So I would see this as a consistent partnership working hand in glove with public health workers. So they're developing the technology, they're working to improve it, and we're working with the communities to educate them, ensure that their concerns are addressed, and they are where they need to be to adopt the technology effectively. So
It might be a cool follow-up study to see, I meant like extension professionals in these countries.
Yeah, so those are the community health workers.
Okay.
Yeah, please.
Okay, so I come from Cameroon, and malaria is actually an issue in Africa. Detecting malaria also is a concern because sometimes you have the malaria parasite. Even when you go through the process of testing it, sometimes it's not, they don't realize if you're positive or negative, but actually you're sick and you have malaria in you. Now you're talking about the saliva-based system, which is very easy to administer, which is so great. And so my little concern was now you're providing this kit to this group of people, teachers, community leaders, and the rest. And coming from a society where I do understand that sometimes these kits might not be used for the purpose for which it was provided, because they might start using it based on whom they know, their family members. How do you mitigate the situation to ensure that the least viable people in the community actually have access to these kits, so that it's not just focused on maybe family members and the rest, because I think that's something very critical.
Yeah, no, so that's definitely a concern of the team. And that's why they wanted to make sure that the dissemination of this technology was not limited to a select few. So it's really the goal of Dr. Diglason to get it into as many qualified hands as possible to try to mitigate that. We're not going to mitigate all cases, but continue to understand that that may be something that we need to consider, so that, you know, we're not, it's not just going to those that we're handing it out in their immediate family. So that's why that broader adoption piece is so important. And that's why we're including the school teachers, the nurses, etc. So their original thoughts were if we just get it into medical health professionals, it may create that paradigm. So
Olivia, do we have any remaining time?
No, sir.
We don't, that's what I thought.